assignment today is to talk about infection prevention in the 21st century, the lesson we have learned from uncertainty. The uncertainty in this session I would define as the things that are quite unpredictable, things that are keep changing, that you really have no clue. But all of the uncertainty that happen in the healthcare that I'm going to mention, causing a lot of changes in our healthcare practices, and of course the 21st century defined from year 2000 and so on. First, I think you would all agree that one of the main certainty during year 2000 is the emergence of SARS. And SARS typically occur from a guy in China in year 2002 and has been rapidly spread to 29 countries around the world, mostly affected in Asia, as you know. When talking about SARS, people always put this PowerPoint, and as you can see here, this clearly demonstrating that Dr. A from China went to Hotel M and then spreading at the Hotel M to 10 people, and then these 10 people returned back to their own country and causing a lot of secondary chain and tertiary chain of transmission, where majority has been the victim by healthcare workers in each country. One point though that people never emphasize is that Thailand is the only country that has no secondary chain or tertiary chain of transmission. And I would like to ask you why Thailand has no secondary chain or tertiary chain of transmission at all. We only have one case of SARS in Thailand. And because we have a good infection control in year 2000, probably not the case. And I think we are very fortunate to have a very knowledgeable patient. This is the picture of Dr. Carlo Urbani, who was sent from WHO to help Vietnam establish infection control. And unfortunately, when Dr. Carlo gets sick, he requested to be treated in Thailand, and upon arriving at the airport, he requested a specific transportation and referred to the hospital in Thailand to deal with SARS, and he suspects himself to have SARS. Of course, at that time, Thailand still have no negative pressure unit at all, or even negative pressure room. We are not available in Thailand at that moment. But the lesson that we have learned from SARS is a good model for Thailand to build upon the future to fight against all emerging infectious disease. And of course, this is the unit that is a historical unit because they're creating the unit to host Dr. Carlo. And Dr. Carlo is here, and they put the exhaust fan to build the negative pressure in the room. They arrange the unit one way in and one way out, and the nursing station is here, and anteroom is here, the contamination area is here, and the place that we keep the supplies here. And of course, we monitor the hand hygiene and compliance to PPE done and doff. And as you can see here, the compliance has been very high. Interestingly, people do culture Dr. Carlo room at that time, and they found that there are a lot of SARS detected in many places in the room. But interestingly, we don't have any single cases detected to have SARS at all, because we're doing a lot of environmental cleaning well at that time. The experience from Dr. Carlo has built the strength on hospital system to fight for emerging infectious disease. And the second emerging infectious disease that occur in Thailand is avian influenza. As you can see here, we have a very close relationship with the poultry, and of course for H5N1. It is a very severe strain of avian influenza that majority of the case had a history contact to the sick poultry, where majority has been severely ill, and mortality has been up to 66%. This is the photo of the rural Thai area. As you can see here, everywhere we have the chicken in the rural area, and also the critical presentation of avian influenza H5N1 strain is so rapid progressive. People have severe pneumonia and likely to pass away. And we also observe that people who receive oseltamivir, which at that time still not available in Thailand, were likely to have less mortality than those who did not receive oseltamivir. Interestingly, the next emerging infectious disease that occurred in Thailand 10 years later than SARS is MERS. And as you can see here, MERS occurred in year 2012. And again, at that time, we have built a very strong capacity to have the system to be able to handle emerging infectious disease. We have a good triage system. We have a good laboratory system. We have a good PPE education. And again, Thailand are able to make zero transmission of MERS again in Thailand. So we have only 3 cases of MERS which occur in Thailand, that all of them came from Saudi Arabia. So this is not by chance, because Thailand must doing a good job. In contrast to some country that have MERS, this is the data from Korea, suggesting that a lot of environmental in MERS case also positive for MERS. But in Korea, this is the cause of transmission to the healthcare worker. At least a few healthcare workers get MERS from environmental that were not cleaned well in Korea. So clearly, Thailand must doing some good things so we can suppress MERS in a very low level. And again, the experience they built upon Dr. Carlo also made Thailand become very famous on handling emerging infectious disease. Thailand has been ranked as the top 5 country to fight against COVID-19. We have a good response to COVID-19. That is because people in Thailand listen to the policy and follow the policy quite well, in contrast to countries in Europe and United States that were more likely to not listen to the policy. Again, I would like to emphasize that after COVID-19, last year we have the monkeypox, and this picture emphasizes the statement that I just mentioned. And indeed, we just invited the European speaker and asked their opinion about containment of the emerging infectious disease. And what they say is quite interesting. They say, well, don't listen to us, you should listen to Thailand, because Thailand doing a good job on contain emerging infectious disease. And this is the case because he was right, because the monkeypox has been widely disseminated in US and also Spain, and has been quite clear. On the Western country and Eastern country have very different pictures of the distribution of the monkeypox. Part of it because of sexual behavior, part of it because of the liberality of the people who can do a lot of things. They don't listen to things that they should do. So this is the case that built upon Dr. Carlo. So altogether, I would have to say that in the 21st century, the first lesson that we have learned from emerging infectious disease is that first, we have a new terminology, opportunistic airborne. Why is it so important? Because in the past, I never have such the terminology, just airborne and droplet. But something like COVID-19, you would not imagine that they put on the nebulizer, they put on the high flow. It could cause a lot of aerosolization. And this has a huge implication for masking for healthcare workers. Secondly, I never learned such terminology of super spreader, where influenza case, one case spreading to 2 people. Influenza is already great. But for SARS, one case they are spreading to 10 or 20 people. This is called super spreader, which is a new terminology, which imply that you have a delayed recognition of the case and a poor triage system that causing the damage for the super spreader. And lastly, the experience that I share with you do emphasize the role of a good environmental cleaning to help suppress or reduce the transmission of emerging infectious disease in the healthcare system. The second uncertainty that is changing all the time is about the quality improvement. And uncertainty like that offer new opportunity for improvement. Talking about this topic, I have to mention that one of the leaders of quality improvement came from the United States. And of course, they have a lot of evidence base, and this is the evidence base to reduce the central line associated bloodstream infection. They come up with a new evidence since 1996 that you have to have adequate personnel, you have to have education and training, people who inserting the catheter, you have to have the chlorhexidine painting, you must have the insertion bundle and put in the guideline, and you should do it in a network to suppress the collapse in less than 1 per 1,000 catheter day. And then they know that chlorhexidine dressing can help reduce the rate of collapse. After year 2009, the CMS come up with a new policy of reimbursement penalty for some healthcare-associated infection in the United States. For example, for UTI, for catheter-associated bloodstream infection, and for surgical site infection that even suppress or reduce the rate of healthcare-associated infection in the United States. But again, I have to emphasize that we are in Thailand. We cannot penalty anyone because it is not the Thai culture. So the way that we really select in state is that we opt to participate. We select to participate in the patient safety campaign from the WHO that leading by Dr. Didier Pité. And also at that time, the Healthcare Association Accreditation Institution that leading by Dr. Anucha has been very active to help issue many policies to reduce the rate of HAI, together with a lot of leadership in healthcare-associated infection, help really strengthen the capacity of our country to fight for healthcare-associated infection. Again, the data from US may not apply to Southeast Asia, and this is the data imply that the healthcare-associated infection burden in Southeast Asia is still much different and also higher than the United States. And of course, we have the problem that different from the United States, where ventilator-associated pneumonia is the #1 healthcare-associated infection, following by UTI and following by collapse. And the magnitude is about 10-fold higher than the United States. Interestingly, we also see different pattern of pathogen in this region as well, where the predominant organism that causing healthcare-associated infection turn out to be a gram-negative, particularly for Acinetobacter baumannii that has been ranked as the top pathogen in this region. In year 2014, we first time do a national survey to survey the practice to prevent healthcare-associated infection. Overall, we found that only 30% or less of the Thai hospital do practice HAI according to the guideline, and we are able to identify several prerequisites for hospital who doing a good job, including the hospital must have hospital epidemiologists, the hospital must have the least ICN certified NIC, the hospital must have a very good support from the leadership, and also the hospital must involve in the HAI collaboration. These are a predictor to have a good infection control program to help fight for HAI. And I would like to thank some key leadership in here to provide education for the ICN and also for the doctor throughout Thailand. This is the last survey that we do during the COVID, and we compared to the 2014. What we found is that in the last survey, the practice to prevent HAI has been even strengthened For example, the practice to prevent UTI has been practiced more. The practice to prevent CLABSI has been performed more. And the practice to prevent WAP has been practiced more compared to 2014. So this clearly is a good thing on the impact of hospital accreditation in Thailand. The third uncertainty is the uncertainty that you probably did not expect. But I think it will happen to your life once in a lifetime. So don't be underestimate what's going to happen to you. And the uncertainty that also happened to my life, which is one of the disaster as well, is the natural disaster. This happened about 12 years ago, that in Pathum Thani, where my hospital located, we have a huge water flood and a 3-meter high of the water getting into my hospital, and we have to close the hospital for 3 months, and all the unit has been destroyed, everywhere destroyed, and the hospital are so different from what we have seen. We also see a lot of fungus in the hospital that you never experienced before. And also you can see a lot of unusual presentation of infectious disease. For example, melioidosis associated with the flood, a pseudo outbreak from the mold or fungus everywhere in the surgical unit, medical unit, and ICU. The only good thing that my colleague also teasing me from this publication is that one of the way to terminate the MDR Acinetobacter is to have the flooding, because after the flood, Acinetobacter has significantly declined. That is because we have a big cleaning day prior to opening the hospital. That's why the Acinetobacter has been declined. But otherwise, it has been a lot of mess. So after the flood, we have an opportunity to contribute to the literature on the infection prevention and control relevant to excessive flood. And we have a plan in place that everyone can look at the literature to see what you should do prior to the flood, what you should do prior to open the hospital, and what you should do after opening a hospital, what you should monitor until the situation is stable. And this has been clearly demonstrating in this figure. And also this review articles seem to be very beneficial to many countries that have the flooding as well, because at least there are some interview of myself that some hospital in the United States do benefit from our review article, from our experience from the flooding to remediating the hospital and the unit as well.